Thank you. Good morning, all. I'm genetic counselor and scientific advisor at iGenomics, India. Thank you, Dr. Jayakrishnan, for the invitation and giving me the opportunity to be a part of this meeting. So my topic is non-invasive PGT, the future of ART. So what are the research, the work that has been done by different groups? Where are we? What is the real application? Is it really screening, or have we reached the diagnostic stage when we do a non-invasive PGT? So I'll start with PGT, pre-implantation genetic testing. We know that the old terminology was PGS or PGD, pre-implantation genetic screening or pre-implantation genetic diagnosis. Now we have mainly three categories: PGT-A for aneuploidies, PGT-SR for structural rearrangements, PGT-M for monogenic disorders, and we can also add PGT-HLA matching for wherever indicated. So these, the PGT, the regular ones, the different types that we have, these are invasive. That is one limitation. This is technically challenging. You need specific equipments like laser. You need trained personnel, and this varies according to the expertise of the personnel who is handling, who is doing the biopsy. Whereas non-invasive PGT, this is aims to obtain representative DNA from the embryo without any contact with the embryo structure. We're not touching the structure of the embryo. So we know aneuploidies are common in human embryos. Incidence is 20% to 80%. Also depends on the female age. As we know, advanced maternal age is one of the risk factors. These aberrations can originate through both mitotic or meiotic events. And 10% of clinically recognized pregnancies present trisomies or monosomies. For women in the later childbearing, that is advanced maternal age, the incidence may surpass 50%. So aneuploid embryos can reach the blastocyst stage and implant as well. We know that there are some monosomies and trisomies, or these aneuploidies, which are viable. So we can have live birth, most common example, Down syndrome. And morphology and morphokinetics are non-invasive embryo strategies, but their ability to identify euploid embryos are still not well established. So we cannot say that morphology, based on the morphology, this looks good. That means we can assume that there is no chromosomal aberration or abnormalities in the embryo. So that is why it is important to screen for aneuploidies wherever indicated, where we know there is an increased risk for having aneuploidies in the embryos before they are transferred. There have been numerous studies by different groups, starting from 2016, 2013, I suppose, where the initial study or the technique was blastocentesis. And this is proposed as less invasive. This is not completely non-invasive. We can call it as a minimally invasive procedure, where the blastocell is collected, and it requires aspiration of the blastocell fluid at the expanded blastocyst stage, but without removing the embryonic cells. There are certain limitations also. So these cells are necrotic or apoptotic cells that are derived, and which can compromise the DNA quantity or integrity. We know that the DNA quality or quantity is very, very important, because finally we are going to take this to NGS when we screen for aneuploidies. There is a significant variation in amplification rates and concordance of the blastocell fluid. There are various groups who have presented with different concordance rate, and the informativity, or how much DNA quality quantity, is obtained from the blastocell. The variation probably stems from heterogeneity and technical expertise in blastocentesis. Again, it differs depending on the personal handling and doing the blastocentesis. So as I told you, this is one of the approaches, initial approaches. There were few studies where blastocentesis, a minimally invasive procedure, was studied to understand what is the concordance rate. And along with that, the next stage was to include blastocell along with SBM. So they combined the blastocell fluid as well as the SBM Together, they have done the NGS analysis and checked for the DNA quantity and finally the ploidy. Next, and the recent studies that we have, this is based on the cell-free DNA. So embryo cell-free DNA is released during the embryo development, and this we can get from the spent media. We can collect the spent media, and we get the cell-free DNA, which gives us an idea about the DNA content or the ploidy status of the embryo, which is growing in that media. So there are three most critical points in non-invasive PGT. One is the cell-free DNA detection rate, again the quantity and quality, how much we can obtain, and accordingly it varies lab to lab what will be the informativity percentage of that of the cell-free DNA obtained from that lab. Contamination with non-embryonic DNA, like cumulus cells, which is very common. So this contamination will not give us the concordance with the inner cell mass or the trophectoderm. Genetic concordance between samples from SCM and the pre-implantation embryo tissue. So these are the three factors where there have been numerous studies, different protocols that has been developed, and different groups have been trying to come to a protocol which gives us the maximum informativity and a higher concordance with the trophectoderm and inner cell mass. So just to give you an example of the studies that has been done so far, the concordance informativity as well as the concordance that has been achieved till now. I just wanted to list few of the papers to show that how much different groups have done these studies, and you have numerous publications so far. For all the three categories, the only blastocell minimally invasive, blastocell as well as the SBM, and finally the non-invasive only SBM, which is completely non-invasive approach. Out of all these studies, the most comprehensive till date, which is the Dr. Carmen's work, there is iGenomics group. There are two studies, 2019 and 2020, which gave a completely non-invasive approach for the SBM and the protocol which is developed for high informativity rate and concordance. So the origin of the cell-free DNA is one big question. Is the embryonic cell-free DNA detectable in spent culture media? Does it represent the chromosome content of the embryo? What are the types of contamination that can occur? What is the source of these contamination? Contamination can also be present in the media. The various components which are being used, the handling, the personnel who is collecting the SBM. So this is one field of research. We are still not completely clear about what is the origin of the cell-free DNA. This is the basic protocol, how we perform aneuploidy testing. On the left side, you can see the conventional PGT-A that is done where blastocyst biopsy is done at day 5 or day 6. 5 to 8 trophectoderm cells are collected, and this is where by NGS, we do the analysis. For example, here I'm showing 45, and this is monosomy 16, normal sex chromosomes. On the other hand, on the right side is the embryo cell-free analysis in the SBM, and it shows similar concordance. So this is the embryo cultured from day 4 to day 6. There are several steps of washings in between, and the cell-free DNA that is collected, we do NGS analysis, and the concordance here we can say is the similar. So this is what we want to achieve. The PGT-A and SBM should have higher concordance and similar results. So as I already told, this is one of the contamination is one of the important factors, because if it is contaminated, that is not actually giving us the real picture of the ICM and the trophectoderm cells. So the sources of DNA contamination can be the cumulus cells, external, due to manipulation in the culture media or technologist who is handling. Also, due to the maternal cell contamination or MCC, it can be if the washings are not proper after day 4 embryos. And crucial steps are oocyte denudation and embryo serial washes. External factors, the personnel who is handling should wear PPEs to avoid any contamination So it should be properly covered, personnel, whoever is handling. So the study that I was showing in 2019 and 2020, most recent one, where there is a comparison of the trophectoderm biopsy versus the SBM on day 5 of the embryo. The concordance rate is 63, but if it is day 6, it has been observed it has a higher concordance of 87%. In fact, there are some recent studies. This is on fresh blastocyst. There is one recent study also which was presented in the PGDIS this year by Dr. Carmen, where the concordance is more than 90%. So we are working on this protocol. Informativity is 100%, the protocol that has been developed. And similarly, it's just not iGenomics. There are other labs also who have different protocols, but I'm just showing you our research and our development till now, the protocol that has been developed. Indications or the patients who are selected for non-invasive PGT, this is a very important point that we should keep in mind. So couples with or without any indication for PGTA. So not all cases, we need to check for aneuploidies. So some of the indication for PGTA as well as non-invasive PGT would be without any PGT indication for egg donor programs, where maybe there are some basic screening that is already done. Good prognosis patient with first negative beta SCG, or good responders patient with good number of embryos. So we don't have, it's not that less number of embryos are present, where it can be used for prioritization after a non-invasive PGT. So we have good number of embryos to prioritize which one to transfer first, along with the other factors like the morphology or morphokinetics. This can be included as a prioritization system. A patient who have equal to or more than 3 good quality or morphology embryos on day 4, or in cases of unexplained infertility, where we have checked for all the genetic factors, like Dr. Shankar very nicely explained about the factors we should do chromosomal analysis. There are some non-genetic factors also where we do the screening. Everything looks fine. So these are the unexplained infertility cases. You can include the non-invasive PGT for these cases. Or the patients with PGTA indication, but non-invasive approach is preferred. They don't want to go for an invasive one. So some of the cases can be, there are countries where PGTA is not legal. They don't want any invasive procedure on the embryos. Couple who do not want to discard embryos because of ethics or religion. So we can have this prioritization system included. Poor quality embryos to avoid biopsy. There are many cases where we see, based on the morphology, the embryologist says that we cannot biopsy. So we cannot do any further testing for the aneuploidy. For those cases, non-invasive approach is very useful for these patients. If low number of blastocysts are there, that is for the poor responders, advanced maternal age, or recurrent implantation failure, RPL cases, previous pregnancy with aneuploidy, etc., where we do the risk assessment. There is a higher risk for aneuploidies in their future pregnancies. So these are the conclusions. NIPGTA with the analysis of the embryonic cell-free DNA in the SPM is a powerful biomarker, but it should not be currently, with the concordance rate that we have, should not be considered as the substitute for trophectoderm biopsy. So we need to select which patients should go for an IPGT, and we should keep in mind the concordance rate and the other factors. It might be helpful to prioritize to transfer the embryo with higher reproductive potential. We can include this as one of the parameters. All embryos could be considered for transfer according to their priority order, keeping in mind the good prognosis patients that we just now discussed. This could be an attractive option for those patients who want to increase their clinical outcome. There is still the future direction. There is a lot still to do, and there's a lot of research going on. Understanding the origin of cell-free DNA. Once we have clear understanding, this will help us to standardized protocol to get maximum amount DNA quantity and quality wise, which automatically increases the informativity rate for any lab. Identification of contamination and how to prevent that. Once we identify, we can take precautionary measures. The clinical studies for a reproductive outcome, where that is the sensitivity or specificity for these testing. Clinical cases where PGT-SR or PGT-M, that is, if one of the partner is identified with a rearrangement, we know that this can cause imbalances in pregnancy. At present, we cannot offer non-invasive PGT. We have to go for the invasive one. Also for single gene defect, when we know there is a single gene defect risk already identified for a family, currently we cannot offer the non-invasive PGT for those patients. And thank you. That's all from me.